Hi, my name is Alison Spackman, and I will be presenting my project on improving safety and handling of chemotherapy in the operating room. I am currently a student at Maryville University pursuing my doctorate in nursing practice. My committee members include Dr. Joanne Kern, who served as my lead chairperson on the project, Dr. Jennifer Theo, who was my second reader, and Megan DeLay, who holds a bachelor's degree in nursing and was the unit education coordinator of the operating room during my project. As many of you already know, chemotherapy is a standard treatment for a wide variety of cancer diagnoses. The chemotherapy works well at destroying the cells that are reproducing too quickly and causing cancer in patients. However, they can also attack healthy cells, and healthcare professionals must handle these medications safely to protect themselves and other patients from possible cross-contamination. This Doctor of Nursing Practice Quality Improvement Project aims to raise awareness about the potential harm of chemotherapy medications, particularly in units that have not previously utilized these medications. The project emphasized the importance of using personal protective equipment and provided the necessary tools to ensure compliance with hospital policy, supported by peer-reviewed research. For the literature review, the PICO question was, does the use of an evidence-based hazardous drug waste spill management flow sheet by operating room nurses and scrub technicians reduce the risk of complications from mishandling chemotherapy, improve compliance with hospital chemotherapy agent handling policy, and improve nurses' safe handling of chemotherapy spills as compared to not using an evidence-based hazardous drug waste spill management flow sheet over a period of 8 weeks. To support the importance of the project, the research found that providing education can change a nurse's attitude towards chemotherapy. Cultivating a safety climate fosters a positive perception of using personal protective equipment, or PPE, and its importance. When all staff members are in support of a safety climate, everyone holds each other accountable and improves compliance with hospital protocols. The administration of chemotherapy is increasing in a wide variety of settings, including operating rooms. The purpose is for improved access to care, which is incredibly important. However, so is the training of the staff handling these medications. The mishandling of chemotherapy, even if it is once a month, may cause long-term side effects, including carcinogenic damage, reproductive health damage, organ toxicity, and genetic variations. Surface contamination can occur at any stage of the administration process and spread quickly through hands moving and touching surfaces, as well as walking from one contaminated area and transferring it from your shoes. The risk of exposure then increases from staff to patient and to everyone within the facility. An estimated 8 million healthcare workers are potentially exposed to chemotherapy in the United States every year. Nurses who experience a chemotherapy spill often do not report it, and they do not wear appropriate PPE to protect themselves. Overall, during the evaluation of spills, the reported nurse's response is suboptimal, and appropriate PPE is rarely utilized. Even nurses with certifications in handling chemotherapy do not receive hands-on training on how to safely handle a chemotherapy spill in their unit. Authentic experiences and in-person training are critical for appropriate responses, and an easy-to-find tool that provides step-by-step instructions on handling rare occurrences, such as a chemotherapy spill, is essential for ensuring compliance and safety. The toolkit developed by the Oncology Nursing Society, or ONS, serves as a quick reference for nurses and facilities that need to follow the guidelines established by the United States Pharmacopoeia Convention. The toolkit provides research-backed guidelines and safe handling workflows that the author tailored to the facility's policies. Before I proceed, I would like to emphasize the significance of these findings. What really stood out to me in the literature was the disconnect between the frequency of chemotherapy exposure and the preparedness of staff who are expected to manage it safely. Many studies highlighted that even experienced nurses often felt confident, but when tested, they were not performing the required steps correctly, especially during spills, contamination events, or unexpected emergencies. This gap between confidence and competence is especially concerning in settings like the operating room, where staff may only encounter chemotherapy occasionally. When exposure is rare, confidence can be high, but skills can be low. This project was designed to bridge that gap by giving nurses a simple, clear, accessible tool that supports real-time decision-making. The Plan, Do, Study Act, PDSA model, is the most frequently used theoretical framework for quality improvement projects in healthcare due to its cyclical nature, which allows for continuous improvement as new information becomes available. During this project, the planning step involved recognizing the problem, brainstorming ideas for correcting it, and collaborating with professors at Maryville to create a feasible plan for the project. The Do step involved creating the flow sheet, educational PowerPoint, and competency, and having many leaders review the material prior to dissemination, followed by actually providing the in-services and competency checks to the OR staff. The study step involved analyzing the data sheet and collaborating with the Maryville statistician on the data. The Act step provides the unit with necessary tools to properly implement the use of the flow sheet moving forward, along with ongoing adjustments and communication about new research that may necessitate updates. The project utilized nominal data to assess its statistical success. Before the project, there was no protocol or educational training in place for OR nurses to handle hazardous medications. The training session, which included visual aids, was followed by the introduction of the flow sheet. The author conducted a mock chemotherapy spill competency check, followed 8 weeks later by another that allowed the utilization of the flow sheet. Then the author recommended placement of the flow sheet in an easily accessible area on the unit by the UEC for emergency use. The data was transferred to a collection sheet and de-identified using nominal scales of passed, failed, and remediation. One point I want to highlight about the methodology is the hands-on design of the competency assessment. Nurses repeatedly reported that they had received education on chemotherapy theoretically, but had not been given the chance to practice a spill cleanup. This reinforced the importance of experiential learning. By creating a realistic mock spill, the project ensured that nurses not only recalled information, but also could apply it correctly, systematically, and with confidence. The 8-week time frame allowed us to determine whether the new flow sheet could be reliably used even after some time had passed since initial training. The sample consisted of 20 nurses who worked in the operating room at the Veteran Affairs Hospital and excluded nurses not on the unit for this project. The statistical test used to analyze the data was the z-test for the difference of two proportions, which was employed to determine whether the observed proportion significantly differed from the expected value in the absence of intervention. The independent variable was the introduction of the flow sheet, and the dependent variable was whether the competency was passed, failed, or required remediation. The goal was to determine that 80% of nurses received a pass on their competency assessment. It was also crucial to select a statistical analysis approach that effectively captured changes in real-world practice. The z-test for two proportions made sense here because we were evaluating the difference between two groups measured at two different times. Our goal was not just to see improvement, it was to ensure that the improvement was statistically meaningful, not just coincidental. The statistical significance supported my observations during the competencies. Nurses were more prepared, more confident, and able to perform each step with improved accuracy. The results showed that 20% of staff were competent prior to the intervention and 100% were competent after the intervention. The z-statistic value of 5.1640 suggests a statistically significant difference between the two, and the p-value of less than 0.0001 indicates that the intervention could be replicated on other units and is likely to be sustained moving forward. The findings are encouraging and emphasize the importance of continuous education and updating the flow sheet annually, as well as regular annual competencies to maintain compliance. Achieving a 100% competency rate following the intervention demonstrates the effectiveness of clear standardized tools in clinical practice. However, more importantly, during follow-up conversations with nurses, many of them stated they finally felt they understood what to do during a spill, rather than relying on assumptions or outdated information. Several nurses even expressed surprise once they saw the flow sheet. They realized how many steps they had been unaware of before. This feedback reinforces that the issue wasn't a lack of willingness to follow policy. It was a lack of a supportive system that provided easy access to the correct procedure. Unfortunately, the study has some significant limitations. For example, the sample size was small and focused on the operating room, which limited generalizability. The author served as the sole evaluator for both pre- and post-intervention assessments, which can lead to observer bias. Lack of a control group limits the ability to attribute the change to the intervention positively. Due to the sterile nature of the OR, the author was unable to perform environmental sampling to determine if there was a reduction in contamination. I also want to recognize that although the limitations were significant, they provide direction for future work. For example, the inability to perform environmental sampling limits our ability to connect improved competency with actual reductions in contamination. That would be an excellent next step, especially at hospitals that perform high-tech procedures or frequently handle hazardous medications. Additionally, expanding this intervention to a larger and more diverse sample across different units, shifts, and even different hospitals will provide more robust evidence for its broader implementation. Although there were limitations, the project outcome exceeded expectations, reflecting the effectiveness of simulation-based learning and direct instruction, and provided a visual flow sheet as an intervention. The study suggests that the main barrier to compliance was not an unwillingness to comply with hospital policy, but rather a lack of education and tools. One of the unexpected findings from my project was a high level of appreciation from staff about the flow sheet itself. Many told me that having a physical reference tool decreased their anxiety about handling hazardous medications. In a high-stress environment like the OR, having a visual guide reinforces safe behavior, especially during emergencies. This speaks to a larger concept in healthcare: simplicity saves lives. When tools are accessible, clear, and grounded in evidence, compliance tends to increase naturally. Tools like this help establish a culture of safety, which is crucial when handling hazardous medications. The intervention demonstrated success, and management should incorporate the tool and education into annual competencies, as well as during new hire orientations. Future studies could investigate long-term skill retention, evaluating environmental swabs before and after implementation, and expanding this approach to other units throughout the hospital. Looking ahead, the success of this project suggests that even small, well-designed interventions can have a major impact on safety culture. As chemotherapy administration expands to more settings, hospitals require standardized tools that support both new and experienced nurses. Incorporating the flow sheet into orientation, annual competencies, and real-time practice will help sustain these results. Additionally, as USP and ONS guidelines continue to evolve, it will be essential to regularly review and update this flow sheet. This ensures that the tool remains aligned with the most current evidence and regulatory requirements. The project completed its goal and increased awareness about handling hazardous drugs in units outside of oncology. The hospital later initiated a hospital-wide education program and continues to expand on this intervention. From completing this QI project, I have learned about the numerous steps involved in completing a QI project, and that healthcare is continually evolving, requiring new leaders to continually try new ideas to improve the quality and safety of healthcare for everyone. As we reflect on the significance of this project, it is essential to emphasize the critical importance of chemotherapy safety beyond oncology units. Operating room nurses often focus on surgical priorities. However, as chemotherapy procedures expand into the perioperative areas, this creates a unique intersection where safety standards must be just as stringent as those in specialized cancer centers. Many nurses in the OR have never been exposed to this type of training before, so increasing awareness was an essential first step in preventing accidental exposure and reducing potential harm to staff and patients. One of the key takeaways from this project was that the barrier wasn't resistance. Nurses wanted to do the right thing. What they lacked was the consistent education, a standardized process, and an easy access visual reference during high-stress, fast-paced scenarios. By providing a flow sheet rooted in ONS standards and hospital policy, we removed ambiguity. We provided a team with clear, quick, and reliable guide that supported safe behaviors in real time. This helped build confidence, and you can see that confidence reflected almost immediately in the post-intervention competency scores. Another point is that this project demonstrated the power of simulation and hands-on learning. Nurses often learn best by doing, especially when handling hazardous drugs or navigating complex safety procedures. Through structured practice, they develop muscle memory, which is essential when responding to unexpected spills or exposures. This approach also helped highlight gaps in understanding that may not have been visible in a written checklist alone. Lastly, this initiative showed how small, targeted quality improvements can lead to a larger organizational change. After seeing the results, the hospital expanded this program beyond the OR. That demonstrates how nursing-driven quality improvement can influence hospital policy, reshape training expectations, and elevate safety culture across departments. And moving forward, I hope to build on this work by exploring long-term competency retention, integrating environmental samplings when feasible, and expanding training modules into other high-risk areas. This project has strengthened my belief in the impact of nurses can make when we combine education, evidence-based practice, and leadership to improve patient and staff safety. Looking forward, I already have some additional ideas that I look forward to exploring to improve efficiency in my first year as a DMP, and I have already started collaborating with my preceptor on these ideas. Here are my references. And if you have any questions or concerns, please feel free to reach out to me and contact me via email. Thank you so much for your time and listening about my project. Have a great day.